So as with every year for the last couple of years, we have opened the conference with stroke and getting woken up about some exciting stuff in the world of stroke and the central nervous system, and then I come up and talk about the peripheral nervous system and put everybody back to sleep. But the good news is right after this there's a break, so you guys can fill up on coffee after this. But I'm Bob Marquart. I have the privilege of being one of the co-directors of the course, along with Glenn, and so it's an honor to be back here again. I see a lot of familiar faces of people who have come back year after year, so I appreciate that. And for all the newcomers, hopefully you find this a very rewarding experience and a good educational experience to help take better care of your patients. So I chose to talk about polyneuropathy this year, and I didn't have a specific part of polyneuropathy that I wanted to talk about, but through a couple of cases and a couple of slides, just to highlight a couple of things that I've seen over the last couple of years that I think are important to at least think through, some differentials to hopefully help you guys sort through these people. And so we're going to do this and hopefully stay on time. Here's my disclosures. And so how we're going to do this is go through some basic definitions just so we're all on the same page about what polyneuropathy really reflects. We're going to go through a case based on time-based presentations, a case based on the electrodiagnostic considerations, and a case based on risk factors and thinking through those. And so when we talk about polyneuropathy, I think it's important to at least have a general understanding of what I'm referring to, okay? Because when we talk about the peripheral nervous system, right, what we're talking about is predominantly a distal and length-dependent process when we talk about polyneuropathy. We're not talking about plexus disorders or root disorders or things like that. They typically will have sensory and or motor symptoms, sensory obviously being much more common, but they can be both. It tends to be symmetrical. And this is kind of how we think through anybody with a polyneuropathy. So no matter how they come in, if they have distal, length-dependent, symmetric presentations, and you think it's coming from the peripheral nervous system, the American Academy of Neuromuscular and Electrodiagnostic Medicine, which is kind of our neuromuscular national group, all patients should start with these things. And so we're going to get this out of the way because everything after this is going to build upon this, okay? So checking a blood glucose, so it can be a fasting glucose, it can be a hemoglobin A1C, which is the much more common way of doing things these days. You can certainly do a fasting glucose test and things like that. A B12 and a metabolite, so the one we typically go with is methylmalonic acid because it is more specific to B12 than homocysteine is, and then looking for paraproteins with serum immunofixation, looking at the type of M protein and electrophoresis, giving you the amount of it. So either one would be acceptable. But this is what we recommend for all patients, just to screen them from a cost-benefit standpoint. This is what's felt to be the most reliable. My additional recommendation into this is, given the commonality of alcohol, is I think you have to hammer down in all of your patients how much they're drinking, how often they're drinking, and things like that. Especially since the pandemic, we've seen the rates of alcohol use and abuse kind of go up somewhat dramatically, and so make sure you're screening all of these people. From a time course definition standpoint, for the cases and things that we're going to be talking through, acute, we don't really have great definitions, but these are the way I think about it. Acute would be presenting within days to weeks, subacute weeks to months, and then chronic months to years. And then when we talk about electrodiagnostic definitions, again, keeping it as simple as possible. We have two forms of polyneuropathy that we think about. Axonal, which is predominantly reflecting damage to the axon itself. Reduced amplitudes on sensory and motor nerve conduction studies is how we will define that electrodiagnostically. And then demyelinating, there's four major categories that we use. So prolongation of motor conduction latencies, slowed motor conduction velocities, the presence of a focal conduction block, and temporal dispersion on the waveforms themselves. And these are the kind of criteria for strongly supportive of demyelination when you talk about, again, motor distal latencies. And I think I'm not going to read through all of these. You know, these are certainly available for reference and things like that. But some of the more common mistakes that we see in polyneuropathy evaluation is misdiagnosing demyelinating neuropathies, right? So you see a mild prolongation of a motor latency. If the upper limit of normal is 5, you see something like a 5.3, it gets interpreted as demyelinating, and people go down kind of a fishing route for something like CIDP. when they haven't really met criteria. It has to be quite prolonged in terms of motor distal latencies. Similarly with conduction velocity slowing, it really needs to be across that 30% threshold. So if we're thinking about a leg using simple math, 40 meters per second is what we typically consider normal, faster than that. So if we just go to 30, that's 75%, right? So we still haven't even quite gotten there. And so something like a 36 or a 37 meters per second on a conduction velocity, you're really not quite getting to that full demyelination standpoint. And so build yourself cases in terms of looking at these a little bit critically. And then temporal dispersion, again, you want to really see a sort of dramatic increase in that duration of more than 30%. So again, those are the most common ones that we see that are sort of misdiagnosed. So keep those in mind. And so I have an initial question here. Let's see if I've already put you to sleep talking about neuropathy. But what is the AANEM's recommendation for all patients with polyneuropathy? A, checking a glucose tolerance test, immunofixation, B12, and MMA. Checking B, an EMG. C, genetic testing. D, autonomic testing. Or E, both A and B. So mostly A, E's making a push. All right, so we'll briefly talk about that. So the right answer is still A, okay? All of the other, so B, C, and D are recommended in various certain scenarios. We're going to talk through some of this, specifically B and C, because they're not recommended for everybody. They're not really necessary in everybody. Again, if you are seeing somebody who's had neuropathy for 10 years, they've been diabetic for 20, and you have a known cause and they've progressed as you've expected, their exam has progressed as you've expected, then I don't know that you necessarily have to do an EMG or genetic testing or autonomic testing in those patients. But there are some scenarios where it can be helpful. All right, and before we get into the cases, a quick kind of detour. This has been one of the biggest debates, I think, that in terms of interesting debates we have in neuromuscular medicine in neuropathy. The long-standing fight has been, can pre-diabetes or, in the glucose intolerance range, can that cause a sensory neuropathy? And for a long time, there have been several studies out of, for example, the Mayo Clinic, where they have found no increased risk of developing a neuropathy comparing pre-diabetics to normal controls, okay? And they only looked at pre-diabetes. There's been some work from Virginia and some other places that have kind of revisited this idea in the last couple of years. And again, this idea of metabolic syndrome has been the focus that they've had. And it's incredibly common. It's becoming more common. And again, the older a patient is, the more likely they are to have this. And we're finding that it actually may end up being a major cause of cryptogenic stroke, specifically sensory predominant. I'm not going to go over every part of this, but again, metabolic syndrome, to remind everybody, has criteria in terms of basically vascular risk factors, so looking at triglycerides, your HDL, your blood pressure, your glucose levels, and obesity. And then if they meet certain criteria, depending on which group you're looking at, then they can be diagnosed with metabolic syndrome. So this is what they were looking at. And they published a nice paper in 2021 that it actually may not be specifically related to the glycemic index of the patient, but more to do with the dyslipidemia and the waist circumference, that those two combined have a significant risk of developing a sensory polyneuropathy. And that doesn't necessarily occur outside of metabolic syndrome. And so it's when they meet the criteria altogether. And this has kind of further been studied. They've showed that, again, in type 2 diabetics, it kind of supports this hypothesis because lipid-lowering therapy actually will reduce the risk of developing diabetic polyneuropathy in type 2 diabetes. And so, statins aren't only for the vascular neurologists of the group. This is something that even we in the peripheral field are starting to think about more. And again, cardiovascular exercise has been shown to be the best form of treatment in terms of reducing symptoms and reducing chronic burden of progression in these patients. And so this is something that we're paying a lot more attention to, that we're actually starting to look at lipid profiles of our patients, even in the peripheral clinics, and it's something that we're really thinking through. And so it's something certainly anecdotally that I've seen over the years, that people who are diagnosed with idiopathic neuropathy, a lot of them do meet this criteria, and there may be some counseling that you can offer those people. All right, so moving on to just some cases and some of what I think is more interesting things. Again, these are things that I think are just good to and useful to think through in terms of differentials and kind of workflows and how to work these patients up. And for these cases, we're going to kind of be on the same page that all of them have had those initial labs checked and they are normal. None have received any medications that would be contributing, like chemotherapy or checkpoint inhibitors. They're all completely abstinent from alcohol, and they all have clinical exams that are at least consistent with polyneuropathy. So that's kind of the baseline understanding that we're going to have. All right. First case. So 65-year-old male comes in with progressive numbness and tingling in the feet. Sounds like polyneuropathy. And so the question really is this concerning? And so when somebody that we've started with those baseline features, we know their labs are normal, they're not drinking alcohol, we have to dig again into the history. Well, are we concerned if he also has some vague abdominal pain? And I'm going somewhere with this, but this wouldn't really be concerning in a 65-year-old, at least yet, right? A lot of people have abdominal pain for various causes, could be GERD, who knows. But now you find out that it's progressed upwards over 3 days. You're noticing by day 5 that he's actually developed a bilateral foot drop and he's got some hand weakness. Okay, so now all of a sudden we've met our red flags, right? This is actually very concerning. This is an acute neuropathy that's progressing very, very rapidly. And so this is his initial EMG, and I'm not going to make you all interpret these necessarily, but at 65, we would expect all responses to be present and normal. So again, somewhere between the age of 70 and 75, you might lose your sensory nerve conductions, and that might be a normal part of aging. Certainly at 65, they should be present. So we have an absent sural and superficial perineal sensory response. And then when you look at the motors, we have absent motors in the feet. And then we have a very low amplitude motor response at the tibialis anterior of the perineal nerve. So even somewhat, just below the knee, we have very low amplitudes. On needle exam, we're not seeing a whole lot of chronic change. So again, duration, amplitude, and phase in terms of motor unit action potentials, but we are seeing a lot of fibrillations in a lot of positive ways. So a lot of active acute motor axon loss or active denervation going on. So again, with this time course and this EMG, this is a fairly concerning presentation for neuropathy. But if we quickly go back, there are no real demyelinating features, right? So if we look at the latencies, well, these are absent. And despite these amplitudes being very low, sometimes you'll see secondary demyelination with these, so you'll have mild prolongation of the motor latencies. But here we see a completely normal latency, we see a normal conduction velocity, and take my word for it that there is no dispersion of this slight drop in amplitude here. So we have an acute axonal sensory motor polyneuropathy. And so this is kind of what I wanted to talk through and what I wanted to discuss about abdominal pain, because it's one of the common things that we see when we're in the hospital. People who come in with acute abdominal pain or an abdominal syndrome along with their neuropathy. Almost everybody's brains will go to Guillain-Barré syndrome in that case. And probably 9 times out of 10, you're going to be correct in that. But this is kind of the way I would recommend seeing these patients through their hospital course. Again, you'll always check the initial labs. They were normal in our case. And then I think the best next step is to obtain nerve conductions. I'm going to give an alternate approach because nerve conductions obviously aren't ubiquitously available to everyone at all hospitals. But I think the EMG is really the best way to separate out your pathology, right? Is it axonal or is it demyelinating? Because the differential will change dramatically. The most common misdiagnosis we see for Guillain-Barré syndrome is actually this top one, this acute nutritional neuropathy, which is something that's come out fairly recently. People who have significant recurrent vomiting or a GI prodrome, and then they end up basically with thiamine, B1, and folate deficiency, and they can end up with this type of an EMG. They can present very, very rapidly. But certainly if you end up down the demyelinating route, Guillain-Barré would be your first consideration. Acute onset CIDP, you're not going to know at the time. That'll be delayed. But again, other abdominal symptoms that you might consider would be things like porphyria and vasculitis causing abdominal symptoms. But this is kind of the alternate approach. Again, when nerve conductions aren't immediately available, this is how I would think through it. So an MRI of the lumbar spine with and without, and obtaining spinal fluid. So again, looking for nerve root enhancement to support either inflammation or demyelination, and then spinal fluid, again, looking for that protein elevation with a normal white blood cell count, because those are going to also help you separate these out. In terms of your differential, if you're seeing this linear nerve root enhancement or this cytoalbuminologic dissociation, you're probably pretty comfortable going down the demyelinating route at that point and managing it as GBS. You know, you're probably not going to go wrong because all of these other differentials, with the exception of Lyme disease, that would have an abnormal spinal fluid. These other ones are most likely going to have a normal spinal fluid profile and a normal MRI. So if you are not seeing the things that point you towards demyelination, consider these in your differential, okay? And there are very easy labs to send for these. And so again, I have a huge list here. I'm not going to go through all of these, but again, when you're talking about things like vasculitis, looking for autoimmune disease, and complement levels, looking for your vitamin levels, specifically B1 seems to be the main contributor to an acute nutritional neuropathy. And I'm going to point out urine porphobilinogen. Again, porphyria is incredibly rare, but if you have an axonal EMG or you're not seeing the other markers of GBS, it's a very easy spot test. It's going to be either elevated or normal. If they're in an acute crisis causing a severe neuropathy, it's going to be elevated in the porphyrias that would actually do something like this. It's a very easy test to do. And then we'll talk about nerve biopsy a little bit later in the talk, but nerve biopsy is something to consider in these patients if you're not getting an answer. Again, vasculitis being one of the main reasons we might do this if you have access to it. All right, so our patient, getting back to him, he has progressed very rapidly. His nerve conductions showed a very clear axon loss pathology, and so that puts us in this bucket. And so, again, we did not manage this person as Guillain-Barré syndrome. But again, without those nerve conductions, that would have been difficult, so we would have done the spinal fluid and the MRI. But he ended up having an elevated porphobilinogen. So even at the age of 65, you can actually see these patients come in. A lot of times, if you get into the history, they've actually had a slow burning neuropathy for a very long time. They may have been called idiopathic. They may have been called diabetic if they had mild diabetes or prediabetes. Actually, in this guy's case, he actually did have prediabetes, so his initial neuropathy was attributed to that until he went through his crisis. But especially with abdominal pain, these are, again, some of the things that you would want to think through in your GBS differentials. And we have actually seen all of these things come through our hospital in the last year. And so even though they are distinctly uncommon, we do see them. So at least have this in the back of your mind, even though, again, 9 times out of 10, it's going to be Guillain-Barré syndrome. All right. Case 2. So now we have a 71-year-old. Again, same presentation. So sounds like a polyneuropathy, progressive numbness and tingling in both feet. And again, is it concerning? Well, this time it's progressed upwards over 4 weeks. Okay, so a little bit slower. But it's progressed in that month to basically be the point where he really can't feel his feet. He's starting to fall sideways. Okay, so very big balance disorder within a month. We're starting to get concerned about that, right? That's a fairly rapid progression. And certainly in month 2 of symptoms, now he's noticing weakness. So now we don't just have sensory symptoms, we have motor symptoms. And so we do nerve conductions in this gentleman. They are also absent, again, somewhere between 70 and 75. Absence is okay, but certainly we would take note of it. On motor nerve conductions, so again, we have somewhat low amplitudes here, so anything higher than 3 and 8 for the perineal and tibial respectively would be normal. But the difference here is we actually have somewhat significantly prolonged motor latencies. So at the perineal, we're around 9, and at the tibial, we're hovering around 10 to 11. So again, almost double in terms of the motor latencies. And so we're starting to say, well, you know, is this axonal or is it demyelinating? Then we look at the conduction velocities. We see that they're below 30 for the most part. So now we've built a case, and I always say that demyelinating changes typically come in 2s. So if all you saw was just mild prolongation of motor latencies, but the conduction velocities are normal, there's no conduction block, there's no temporal dispersion, as an isolated finding, you might ignore that, okay? If you start to see 2 or more findings, then you're starting to build a pretty strong case for demyelination. So here we see very clear evidence of 2 separate categories of demyelination. So now we go to the needle exam, and again, very similar to the last case, we're seeing a lot of sort of length-dependent active denervation, right? So below the knee, once we get above the knee in these muscles, it disappears. And then we have some chronic changes, but this is a sensory motor polyneuropathy. It has mixed axon loss and demyelinating features, right? So we had some reduction in amplitudes, but we also saw those secondary demyelinating features. But once we get to those degrees of demyelination, that would be primary demyelination. And so this is how I think about subacute patients, okay? A lot of the differentials are very similar, but it's very expanded. And I wanted to draw a couple of, I guess, points on this slide in particular. Again, these are somewhat busy, but again, in these patients, subacute presentations should always get an EMG if you have access to it. Because again, this is how you're going to determine whether you have an axon loss process or a demyelinating process. And the differential shifts dramatically depending on what you find. In terms of axonal processes, I think some of the ones that we see that are frequently sort of either misdiagnosed or not treated at all. So Canda and Canomad is an interesting group of disorders. So chronic ataxic neuropathy with dialosal antibodies. These are ganglioside antibodies, so GD1A, GD1B. These are labs that you can send clinically. The O in Canomad stands for ophthalmoparesis or ophthalmoplegia, so they can look sort of like a Miller-Fisher variant. They get sensory ataxia and ocular paresis. And then certainly vasculitic processes. We already talked about that none of our patients have gotten chemotherapy or things. But you're also starting to get into heavy metals. Anti-mag neuropathy can show up as an axon loss process. If you don't catch it soon enough, it can progress rapidly enough to the point where all of the responses are absent. And if all of the responses are absent, you can't possibly find any demyelination from a conduction velocity standpoint, for example. In the demyelinating group, one that I wanted to kind of bring special attention to is these nodopathies and paranodopathies. These aren't necessarily new as of 2024, but over the last couple of years since we've talked about polyneuropathy last, these are patients that present almost identically to CIDP. They will typically have a demyelinating EMG, but then they don't respond to IVIG. So any person that you think has CIDP, elevated spinal fluid protein, MRI root enhancement, demyelination on their EMG, you give them steroids and IVIG, and they're just not progressing or responding like you would hope they would, consider a nodopathy. And so the poster child of this is something called an NF155 antibody. So down here. So these are clinically checkable. You can send a lab. So Mayo Clinic has one. Washington University has a lab that checks for these. But these are patients that respond wonderfully to rituximab. And so if you have a CIDP patient in your practice who's not responding well, consider sending this and then switch them to rituximab if they're positive, because they can get dramatically better even despite having some substantial axon loss on their EMG. So this is the way I think about it. So if they have a sensory ataxic phenotype at the time they come in from a subacute standpoint after a month or two, I think the main considerations you'll actually have, meaning they don't have a tremendous amount of motor involvement, anti-mag neuropathy. So typically mag neuropathy will have also an IgM protein with it, but it doesn't have to. It can exist on its own. And then ganglioside antibodies if you have access to sending them. Again, there are national labs that offer these, but specifically the GD1A and GD1B antibodies that are associated with Canda and Canomad, because those are treatable conditions. These are patients that will respond to IVIG. And then if they have more of the classic CIDP phenotype, meaning they're not just a polyneuropathy, even though they might start as a polyneuropathy, when you examine them, they have some proximal weakness too in the arms and legs. I tend, again, if everybody that I see nowadays, I will send a VEGF. So that's looking for Poems syndrome in particular. If you see significant elevation in VEGF, typically over 100, that would be a sign that maybe you're dealing with a Poems patient. Ganglioside antibodies, and then an NF155 antibody. I pretty much send that in anybody who I initially suspect of having CIDP anymore, because it changes the treatment paradigm completely. Okay? And then I will get an EMG in all these patients. If it's axonal, these are other things to at least consider. And again, if it's demyelinating, chances are at that point you're probably just dealing with CIDP. And then you can get these additional workups versus just treat them if you're convinced. But then if they have a poor treatment response, checking those nodopathy antibodies if you haven't already. All right. So for our gentleman, again, he was noticing weakness at month 2. He had some distal demyelination on nerve conductions. So that puts us right smack dab on this side. So he was demyelinating. He had a distal predominant clinical presentation and EMG. So he's not the radiculoneuropathy or the proximal and distal phenotype. So this is primarily what we were considering in him. And his MAG antibody ended up coming back above the upper limit of what we could even detect. So he was treated appropriately and did really, really well. All right, case 3. So same exact presentation, 68-year-old person with progressive numbness and tingling in both feet. Again, is it concerning? We don't know. So this time it's progressed somewhat upwards over 3 years. It's now progressed up to his ankles. He doesn't really have any balance issues. He lives his life. There's no ankle weakness. He has nothing in the hands. And so this is more of a classic presentation that we might see in our clinics more often on the outpatient side of things as opposed to the hospital. This is his initial EMG, so we see very, very mild reduction in sensory amplitudes, right? They should be higher than 5. And then on motors, they're essentially normal. So we have normal amplitudes, we have normal latencies, normal velocities. And so this is a very mild sensory predominant polyneuropathy electrodiagnostically. A needle exam just to confirm, again, we actually see no active changes, we see no chronic changes. So very mild polyneuropathy. So the question is, again, remember we started from a baseline. He has a normal glucose tolerance testing. He has no alcohol use, no medications that have kind of caused things. And so what do we do with these patients? Do we just call them idiopathic, or are there other things that we can offer these people? So again, as with everything, I think going back and reviewing the history is so critically important, and again, understanding what their background is. Again, as I pointed out early on, really, really digging in about alcohol history. It'd be a great study for someone to do, but there's a building theory that people who, we all start off with 100% nerve health, right? When we're born, presumably we don't have a genetic polyneuropathy, that we start off at 100%, all our nerves are perfect. That over time, depending on the environment we're exposed to, different things that we are either ingest from alcohol to our work environment, whatever, that the way we live our life throughout the years kind of will start dwindling away at that 100% nerve health. And if it's not fully recovering over time, that people are just sort of slowly building damage and accumulating that damage, sort of like white spots in the brain, right? Initially, it's not a problem, but if it goes on long enough and you're not controlling for those things, that maybe in some people who don't have a clear history right now, but 30 years ago, they weren't living the best lifestyle, that eventually it might only take a very small hit in the moment to have them cross a threshold where they start to feel a neuropathy or start to have clinical signs of neuropathy. Nobody's done that yet, but it's something that when you go through anecdotally in patients with clinic, you can start to build that history that maybe that what is idiopathic now just has been a chronic accumulation of risk factors over a lifetime. No good evidence of that right now, but again, alcohol, I think this is where family history comes into play. So any more amyloidosis in particular is kind of a never miss diagnosis for a neurologist nowadays in patients with neuropathy, given that it is treatable. Risk factors for vitamin deficiencies, so eating disorders, history of inflammatory bowel disease, overly restrictive diets. Again, historically, right, we're all taught vegetarian and vegan and B12 deficiency, but nowadays we're seeing a lot of people on things like carnivore diets, paleo diets that may be missing some of the vegetable side of things. And so really be thinking through some of those. Bowel resection histories, gastric bypass surgery is probably the most common one that we see in terms of risk factors for vitamin deficiencies. And it's not always going to be in their EMR, right? If you're seeing someone for the first time and you don't have their full history, make sure you're asking about these things because it can change your idea of what they might have dramatically and limit how much testing you actually have to do. And then as I pointed out, I think, again, these are people that you really want to ask about metabolic syndrome. So even if they have a normal A1C, as it stands right now, with the best available evidence, I think there is a role to be checking these people in terms of their other vascular risk factors, particularly things like triglycerides. For whatever reason, triglycerides in particular seem to have a very high, they seem to be the most important lipid in terms of a risk for developing polyneuropathy. So in people with mild sensory symptoms, that's something you can offer them and counsel them on. All right, so this is the way I think through kind of chronic time course. So patient with a clinical polyneuropathy, you kind of go through things I just mentioned. If you come up with targeted testing after your history and you get an explanation, I think you can manage that condition, right? So if you find a person with gastric bypass and they have a B12 deficiency with a mild sensory neuropathy, I think you can manage that B12 deficiency and move on, follow them up. If they're not progressing, great job, right? I don't think all of those people even need an EMG when they're coming in with a mild sensory neuropathy, and clinically that's what they have. You can certainly do it, you're not wrong, but I don't think all patients actually need that. But if there is unexpected progression, so you have the gastric bypass patient, they're B12 deficient, you give them B12, but their neuropathy continues to progress despite adequate replacement, I think at a minimum that is when you should be considering things like genetic testing. Because again, amyloidosis is sort of a never miss for patients right now. And then the way I do my practice, because I am a part of our amyloidosis center, so I do a lot of genetic testing, more than most of my colleagues, but even in the absence of being part of an amyloid center, if you have a younger patient or they have a positive family history, they have certain cardiac risk factors like unexplained left ventricular hypertrophy, certainly if it's septal hypertrophy, then I think going as a part of your initial workup, I think genetic testing should be considered in those people anymore. Because again, it's a treatable condition. If you don't treat it, it's going to progress and it can be fatal. So that's the way I think through these. So again, in terms of targeted testing, I'm not going to go through all of these. But again, really hammering on people on their GI history, their history of alcohol, the metabolic syndrome issue, and then depending on their exam can sometimes point you in one direction or your EMG for that matter. But if they're sensory predominant on exam, if they're small fiber predominant, that might lead you down an autoimmune road, a B6 deficiency, things like that. If they're large fiber, more of a B1 copper folate road in terms of the pathophysiology of those different disorders. All right, so our gentleman he started denture cream about 4 years ago, and his copper ended up being 14. This is kind of a classic. So denture creams historically have had zinc in them, and so it can impair copper absorption in the gut, and so people can develop a copper deficiency. It mimics B12 deficiency. It's very treatable, so something to consider. All right, question number 2. When should a peripheral nerve biopsy be considered? A, any polyneuropathy. B, when you have suspicion for an infiltrative disorder. C, when you have suspicion for vasculitis. D, suspicion for a genetic neuropathy. Or E, both B and C. All right. So big push for E. Yeah. So this has actually been pretty well looked at in terms of cost benefit and what you actually get out of a nerve biopsy. There's a lot of issues with nerve biopsies, but in general, I think the role anymore is becoming more and more limited to very, very specific clinical phenotypes or presentations. I think if you have electrodiagnostics and there's prominent active denervation on it, meaning fibrillations, positive waves that are sort of disproportionate to what you might have expected for any other risk factors the patient would have had, I think that you're not wrong in almost any case to do it for that alone. Because those are patients that are have a very high likelihood to progress if you don't find the cause, and so you should be a bit more aggressive in terms of what you do. I think in terms of lab testing and genetic testing and other things can certainly be done first and probably should be done first because they're less invasive and you might get an answer. But if those things don't pan out or you're not sure what else to do, I think a nerve biopsy is still relevant in those patients. Because chances are you're dealing with one of these things down below. So vasculitis is probably the most common thing that we would do it for if we have a clinical suspicion. Certainly if they have a rheumatological history, or again, they have other systemic features. They have unexplained rashes, fevers, weight loss. They have, again, prominent abdominal symptoms, which would, again, suggest maybe a medium vessel vasculitis of the abdominal arteries. Those would be patients at a very high risk of neurological complications. And then same thing with mononeuritis multiplex. So if you have a very asymmetric or sort of piecemeal presentation, somebody's getting a wrist drop and then they're getting a foot drop on the other side and it's kind of jumping around, those are patients that you should strongly consider doing a nerve biopsy to make sure that you know what you're looking for. Everything besides that is very much you may not get much out of the nerve biopsy. The reason being is amyloidosis in particular, I just talked about it, in the advent of essentially free genetic testing, you're going to get an answer much easier than that. You can biopsy a carpal tunnel and get an answer for amyloid, and which is a much lower risk than doing a nerve root biopsy. Sarcoidosis is another interesting one. Again, typically we will see a small fiber predominant neuropathy with sarcoid. It's the most common presentation, but you can get mononeurous multiplex presentation. You can actually get granulomas that actually develop in the nerves, some of the large nerves. And so again, the problem with either of those two is amyloidosis and sarcoidosis are very piecemeal. And so even if you have a defined diagnosis and you want to go looking for it, the odds that you biopsy the exact right spot to find those things is very small. And then CIDP, remember, you can look for signs of demyelination, but with EMGs being fairly easy to get, with MRIs being much easier to get, if you have a patient who looks like they have CIDP, they have no reflexes, their lower motor neuron, their EMG has demyelination, their MRI has nerve root enhancement, I don't see the role really for these patients anymore doing a nerve root biopsy, or a nerve biopsy rather. But it's still not necessarily wrong to do it, and you could consider it if you don't have access to the other things, or if you're still just not sure what's going on with your patient. And so I'm going to give 4 minutes back here, which is unusual, but do you want to say something? All right. I'm going to invite Glenn back up.